Good evening, everyone. We are delighted to welcome all pediatricians for today's Pediatrician Pathshala Scientific Convention Module 2, Issue 5. We are pleased to announce the successful completion of Pediatrician Pathshala Module 1 last year, where we explored 5 crucial aspects of rational use of antibiotics in respiratory tract infections. This year, we have launched Pediatrician Pathshala Module 2 and successfully covered 4 crucial topics with Dr. Keyur Mahajan, Dr. Bhaskar Shinoy, Dr. Bal Subramaniam, and Dr. Jagdish Chinappa. Today, we will cover exciting topic which would be of great interest to all the pediatricians who joined us today. Now, I would like to hand over today's session to Dr. Vanmati, who is pediatrician and who practices in Chennai, to introduce our today's eminent panelist and continue today's program. Over to you, Dr. Vanmati.
Thank you, Sureka. It's my pleasure to welcome you all to the Pediatric Pathshala Module 2, Guiding Light to Excellence. So, in this module, we have scientific CME series on rational use of antibiotics, and there is also interactive question and answer platform. There are also videos regarding experts' view to excel the pediatric practice. There are also updates on antibiotic resistance. So, this is a Pediatric Pathshala website in which we have we can download our books such as the pediatric companion book and the book on rational use of antibiotics. You can download the book by clicking on the icon there. And we have in this website, we have uploaded all the videos that have been completed in the module 1. We have the 5 videos, and in module 2, the finished videos have been uploaded there. You can watch it anytime. And you can generate the certificate for participation for today's module by clicking onto the icon there, the participation certificate icon. And this certificate of participation will look like this. So today's module is on issue 5, demystifying the common viral infections. So it is my pleasure to introduce today's speaker, Dr. Jaydeep Chowdhury, and today's session will be moderated by Dr. Pramod Jog. So today's speaker, Dr. Jaydeep Chowdhury, is a professor of Department of Pediatrics, Institute of Child Health, Kolkata, and he was a vice president of Central IAP in 2019, and he was a chairperson IAP Infectious Diseases in Chapter 2020, and he was a convener of IAP ACDIP 2015 to 16, and he is the editor of textbook of pediatric infectious diseases, FAQs in pediatric infectious diseases, tropical diseases, etc. And he is the author of clinical consult series, pediatric infectious diseases, etc. We welcome you, sir. And our session is moderated by Dr. Pramod Jog. He's MD Pediatrics, DMD Pediatrics, FAAP and FISCMPH. He's a professor of pediatrics and head of family medicine department, DY Patil Medical College, Pune. And he was the president of IAP 2016, and he is a former standing committee member, International Pediatric Association, and he was a former steering committee member in GAVI, and he is a consultant pediatrician at Medico and Jupiter, Deenanath at Ankura Hospitals, Pune. And I hand over the session to Dr. Pramod Joseph.
Thank you very much for those kind words about Jaydeep and myself. And today we are going to discuss a very important topic related to viral infections. And basically, the word virus has become so viral that almost everyone in the family these days asks me, sir, when a child is having fever, whether it is viral. I will tell you, recently one small little child came to the OPD, and the child had a doll in the hand. And while I was examining that child, the child was speaking to the doll. Don't worry, it's viral. So even small children, they know what is virus. Of course, the point is that gone are the days when we were not much worried about the viral infections. These days, the viruses are changing, okay? They are changing their way of presentation. For example, I'm sure Dr. Jaydeep will cover adenovirus in his talk, which is now showing prolonged, fever. It is showing presentation like lobar pneumonia and so on. So the point is that the viruses are changing their presentation. In fact, we are also able to diagnose the virus by the various panels available. And in case if it is really indicated, then we can go ahead and get the viruses by the PCR. However, some of these viruses like COVID have created havoc all over the world, and that's why we have to be very, very careful. So the respiratory viruses like influenza, the adenovirus and COVID and all, they are creating a problem. On the other side, there are other viruses which attack other systems. For example, hepatitis B virus. In case if it attacks the mother and she delivers a baby, then we are very, very careful about the baby at the time of birth. Chicken pox, for example, if it attacks the mother, particularly just around the period of pregnancy, then we have to take a particular precaution. In certain endemic areas in our country, Japanese encephalitis is prevalent, okay? And we have our all-time friends, dengue and chikungunya. And to top all these, we have new and new emerging viral infections. So, my dear friends, we not only need to diagnose that it is viral, but we also need to be very, very careful in the clinical progression of these viruses. Because after 4 or 5 days, or sometimes 6 or 7 days, these viruses might rather stimulate the immune system in a different way. And just as we had COVID related storm, cytokine storm, after say 5, 6, 7 days, we can have this particular cytokine storm in some other viruses also. So it's very important that we are very, very clear about all the aspects of viral infections. It's a very, very huge topic, but we will try to, complete the discussion within an hour or so. And my friend Dr. Jaideep will take you through the journey of various confusions and problems related to these viral infections, and what are the myths which are associated with the viral infections. And we will try to demystify the various viral infections. So, with this small little background of what viral infections are and how they are creating a problem, I will now request Dr. Jaideep Chaudhary to start with its presentation. So, it's over to you, Dr. Jaideep. Thank you.
Thank you, sir, for setting the context. Absolutely. I mean, you have really given the right platform and groundwork to start the discussion. Thanks, Dr. Vanmati, for uh, giving such a kind introduction, and of course, the Microlabs team for this initiative. Just let me share my screen. I hope it's visible. Dr. Jog, I hope it's visible. Yes. Okay, good.
Yes, yes.
So as rightly Dr. Jog has outlined, that there are plenty of viral infections. But tonight, I will just limit my discussion to few of the common viruses that are happening recently, some confusing points, some myths, and of course, the reality that we are facing. Then again, Dr. Jog has also rightly told that there are many emerging viruses which are posing a great problem to us, the clinicians. So, what are emerging infectious diseases? It is those where the incidence have increased in recent past or threatens to increase in near future. It may be new, previously undefined diseases, just like COVID, say for example, or old diseases with new features that we will discuss few here. And there are some re-emerging infectious diseases, that is reappearance of a disease which was once endemic, then eradicated or controlled. So if we discuss about emerging and re-emerging, of course, viruses hold the center stage. Now here, what's most important is the interaction between host, the agent, and the environment. This is the epidemiological triad of the disease. And mostly there are some vectors which are responsible, but for viruses, it may be some other factors also. So as a host, we are responsible because we are interacting with the environment and the agents are there in the environment. So let us start with few cases. This is a 2-year, 1-month-old girl, high fever and vomiting for 4 days with altered sensorium for 2 days and recurrent convulsion. There is no history of febrile seizures, so it's a new onset convulsion. Development normal. On admission, GCS was 10. There was no cranial nerve involvement, but the tones were increased, the DTR exaggerated, and the plantar were bilateral extensor. So what we are facing? We are facing an acute onset fever, an altered sensorium, and convulsion. So what we are dealing with, this is an acute encephalitis syndrome, and it may be due to various causes. Most commonly in Indian scenario, JE is the most prevalent cause of acute encephalitic syndrome. But JE is not the sole virus responsible. There are non-JE viruses like the enteroviruses. Then there is dengue. Even Nipah and Chandipura may also present like this. And let's not forget herpes, varicella, and others. Then there are other non-viral causes, any bacteria, tuberculous meningitis, even parasites like malaria, fungal, protozoal, sometimes toxins, chemicals, and many cases remain unknown. So it's the host of causes for acute encephalitic syndrome. And JE is definitely increasing if we see. That's why the endemicity of JE also has increased to 336 districts of India, which is more than 60% of India's population. So JE is definitely being detected in many more districts than before. Then there was Nipah virus. It's an emerging bat-borne zoonotic disease. It's a paramyxovirus. It also presents with acute encephalitic syndrome, commonly with fever, headache, myalgia, sore throat also. Sometimes it may present at acute atypical pneumonia. Transmitted by consumption of fruits or fruit products contaminated with urine or saliva from infected fruit bats who are the vectors. And usually it's the raw date palm juice that's consumed. And also it may be transmitted by exposure to secretions from animals like pigs or contact with the tissue of a sick animal, and rarely by close contact with patient's excretion and secretions. And Nipah is not new in India. It was detected way back in 2001 in Siliguri district of West Bengal, then again in 2007 in another district. In Kerala, it was detected in May 2018, and that outbreak killed 21 people. The sixth outbreak in India was quite recent in September 2023. There were 6 lab confirmed cases, including 2 deaths in Kozhikode, Kerala. Then there is Chandipura virus. Of course, the name arises from the Chandipura village of Nagpur, where the outbreak was in 1965. It presents again with acute onset fever, altered sensoria, and convulsion, and it's a rhabdoviridae, and it's a single-stranded RNA. It is transmitted by sandfly, but again, Aedes mosquito recently have been detected to transmit Chandipura virus also. So following the 1965 outbreak in Chandipura village in Nagpur, there have been other outbreaks, particularly in 2003. 329 children have infected in Andhra and Maharashtra, and 183 died. Then very recently, this year in Gujarat, 15 children died because Chandipura virus infection has a case fatality rate 56 to 75%. So going back to our case, which was an acute encephalitic syndrome. So treatment was as usual for any acute encephalitic syndrome: IV fluid, anticonvulsant, ceftriaxone as a broad spectrum antibiotic, acyclovir for herpes encephalitis, and of course neuroprotection. And the child was being investigated. Hemoglobin was 11, total count raised 24,000, neutrophil 65, CRP 60, platelet 82,000. CSF analysis was done. It was no cells, and surprisingly, Japanese encephalitis, IgM, IgG were negative. So this was an acute encephalitic syndrome, not due to JE. MRI brain had abnormal signals, and then further investigations were done. The child had refractory convulsion, loaded with anti-epileptics, ventilated, went into refractory status, and ultimately ketamine bolus followed by thiopenton had to be given. So such a stormy progression. Then what we found, it was dengue IgG, IgM, and NS1 positive, and even CSF sample, which was preserved, showed dengue IgM positive. And the child became afebrile, though, after 2 days, but neuroregression persisted in all domains. There was some improvement, but the child was not 100% neurologically stable even after prolonged follow-up. So final diagnosis in this child presenting with AES was severe dengue fever. Now, dengue might have many neurological complications, though we are more accustomed with the shock and hemorrhage and others. But there may be various neurological complications like encephalitis, meningitis, encephalopathy, acute demyelinating encephalomyelitis, also acute hemorrhagic encephalomyelitis, polyneuropathy, intracerebral hemorrhage, and also GB syndrome. So there may be varied presentation of dengue. We are seeing commonly the hemorrhagic and non-hemorrhagic dengue, but cerebral dengue is also a possibility. So if we see the clinical manifestation of the flaviviruses that we were discussing, flaviviruses, say dengue, chikungunya, JE, Zika, yellow fever, all these are flaviviruses and they present with systemic febrile illness. Neuroinvasive disease is more common with JE. Hemorrhagic is more common with dengue, yellow fever, and Zika. But you see that even dengue may present with neuroinvasive features. So commonly it's flavivirus. And if we see the taxonomy of flavivirus, the tree, you see to the left, the blue one, it's all mosquito-borne. Like yellow fever, dengue, Zika, J, all mosquito-borne. So maybe their presenting features may differ. And on the right, you see the others. So flavivirus, vector, and presentations may be some typical and some atypical. So if you see the mosquito, as we know, is the vector of many diseases, not only the malaria, which is transmitted mainly by the Anopheles. We have the Culicini group of mosquito where there are Culex, Aedes, and Mansonia. They transmit various viruses: Culex, JE, Aedes, dengue, chikungunya, Zika, Mansonia, chikungunya. So Aedes is a serious vector transmitting both dengue, chikungunya, and also Zika. So here you can see the flavivirus, the mosquito as the vector, the Aedes mosquito in particular, and the various presentations. So monsoon, mosquito, and flavivirus, they have a deadly combination, and they are responsible often for such emerging and re-emerging manifestation of the common viruses. Going to another child, 8-year-old girl from urban slum, abrupt onset high-grade fever, 3 days, headache and throat pain, severe joint pain with swelling and myalgia for 2 days, refuses to move, and there are some skin rashes, mainly over the body, diffuse erythematous macules and patches. There is conjunctival ingestion, swollen eyelids. So what we are dealing with, fever, arthralgia, conjunctival congestion, this triad mostly with chikungunya. So we have to think of chikungunya first as the viral infection. But on the other hand, if we see Zika virus, it may also present with low-grade fever, maculopapular rash, non-purulent conjunctivitis, and also arthralgia, which may persist for many months like chikungunya. So the manifesting features may overlap. But Zika virus has another deadly manifestation, which is the congenital Zika syndrome with microcephaly, preterm birth, miscarriage. In India, there were outbreaks, this particularly of the Asian lineage of Zika. 2016, first case from Ahmedabad, later reported from many states. In 2018, Jaipur, there were 159 confirmed cases of Zika virus. Going to another entity which is very new is the Mpox. From July 22 to May 23, there were global outbreak of clade 2B monkeypox virus in 118 countries. In 2024, approximately 200 new infections per month in the USA. And that's why WHO declared it as a health emergency. The reservoir of mpox is rodents, transmitted from animals to humans through direct contact with lesions, body fluids, bite, scratches, contaminated fomite, and also aerosols. So, close human to human contact is a major driver of outbreaks. And of course, through sexual contact, also, it may be transmitted. And you see the various skin manifestation of mpox. The incubation period is 2 to 21 days, and initially there is a prodromal feature with fever, lymphadenopathy, myalgia, malaria, and others. Then we have the evolution of rash, macules to papules to vesicles, pustules, scab, and re-epithelialization, all lasting 1 to 2 days or later pustules and scabs for about a week. The mpox rash classically occurs in centrifugal distribution, mainly involving face, trunk, and limbs. And there may be complications like necrotizing skin lesions, bacterial superinfection, pneumonia, encephalitis, particularly common in immunocompromised patients. The treatment, though not FDA approved, there are few options, but in India, these are not available, few of the drugs, and mainly for adult dosing. Prognosis, generally it's a self-limiting, recover fully within 2 to 4 weeks, but sometimes it may be quite severe. As prevention, the ACIP recommends 2-dose MVA BN vaccine for persons aged 18 years and older at risk for mpox. Moving to another spectrum, 2-year-old boy, cough for 7 days, fever for 5 days, distress for a day, saturation low in room air, tachypnea, chest crepitations are present. You see the chest X-ray, typical right lower consolidation, lower lobe consolidation, WBC 10,000, neutrophil 53, hemoglobin 11, platelet 1.8 lakh, CRP 39, normal was less than 6. You see the typical chest X-ray. Classically, a bacterial, likely a streptococcal pneumonia. So admitted initially to a nursing home for 3 days, where the child received co-amoxiclav for 2 days, followed by meropenem and vancomycin. Then deteriorated on day 3, you see the repeat X-ray, totally wiped out right lung, and transferred to a referral hospital, almost gasping, mixed acidosis, hypoxic, hypotensive with this X-ray. So a POCUS was done, and it revealed right massive effusion with right lower lobe consolidation, minimal septation, collapse of the middle lobe, and intercostal drainage was given, as you can see here, and slightly hemorrhagic hazy fluid came out. As you can see, it's in situ. Hemoglobin repeated 10, WBC 5,900, neutrophil 44, CRP initially was 39, now 36. Other parameters more or less normal. Pleural fluid was done. Cell count 60, polymorphs 10, glucose 145, protein 3.5, ADA was 68, and gram stain was culture, AFB, CBNAT, all were negative. So what are we dealing with? So bronchoalveolar lavage was done. Gram stain was negative. There was no growth. Even AFB and CBNAT were negative from bronchoalveolar lavage. Tuberculin sensitivity was negative. Persistent high fever on day 10. CRP was coming down to 12. Repeat chest X-ray, as you can see, there is definitely tissue damage and tissue breakage. So the child was facing a severe respiratory complication, and the dilemma was that clinically it looked like a community acquired pneumonia. Initial radiology was like lobar pneumonia, but WBC was normal. CRP was decreasing, pleural fluid not matching with pneumonic effusion. And with all the investigation, no bacteria could be isolated, though isolation of bacteria is not very common in pneumonia because it's usually non-invasive bacterial pneumonia. But the fever was persisting on day 11. So these were the dilemma. Now, a bronchoalveolar lavage PCR was done and it showed adenovirus. So we have come to a diagnosis. Fever subsided on day 13 and the child could be extubated on day 14. So this was a presentation of adenoviral pneumonia. As Dr. Jog was telling, it was totally mimicking like a bacterial lobar pneumonia. So the management was in that line, but there were some doubts about the investigation findings and the clinical findings. So ultimately, it came out to be adenovirus pneumonia. And you see, this another child, 1 year old baby, suffered adenoviral pneumonia at 3 months of age, but in between had recurrent admission and often in PICU. Even at 1 year, the child was oxygen dependent. And you see the CT chest, there are bronchiolitis obliterans. So adenoviral pneumonia may have a severe sequelae like bronchiolitis obliterans in this child. And here you see 2 year old, fever, cough and cold, increasing distress. BAL PCR was adeno, ventilated for 3 months, then had to be tracheostomized. And you see the CT chest, typical feature of bronchiectasis, you can see. So adenoviral pneumonia may complicate as bronchiectasis also. It is the second most common virus for viral pneumonia after RSV. And in young children, it may be severe and fatal. And as we saw here, features may be typical like a bacterial disease, and as high as 60% patients do have sequelae vis-a-vis bacterial pneumonia, where sequelae is rare. There may be, in adenoviral pneumonia, there may be persistent wheezing, bronchiolitic obliterans, bronchiectasis, hyperlucent lung, and all. So it may be a quite difficult pneumonia, this adenovirus. And just imagine, few years back, adenovirus was the commonest cause of conjunctivitis. We hardly saw any complication other than red eyes in adenoviral conjunctivitis, and used to pass off just like mild conjunctivitis. But now you see adenovirus presenting with such severe pneumonia. I would just like to show another child, a 10-month-old baby, cough and cold 4 days, fever, distress, was shifted to PICU following 3 episodes of convulsion, and then developed refractory status, intubated, ventilated, multiple antiepileptics, midazolam infusion. CSF analysis was done, and the report was more or less like aseptic meningitis. And then you see the MRI. There are so much in the cerebellum, in the basal ganglia, and also in the cortex. And CSF and respiratory viral PCR both were positive for adenovirus. The child recovered, but there were neurological sequelae. So adenovirus is not the virus which may affect the respiratory system only. It may affect the central nervous system also sometimes. So it may have various presentation. Going to a comparatively rare virus, in a rare case, this is a 3-year-old boy with pre-BALL, standard risk, was on maintenance chemotherapy. The child presented with frequent twitching of the left side of face and involuntary blinking of left eye for 3 days. And there was also difficulty in walking with slurring of speech for a day. Frequency of focal convulsion increased, drowsy, so obviously admitted in PICU. There were focal convulsion of the left face, GCS was 13. Well, saturation 96, you can see the CBG also 112. There were left lateral rectus palsy, pupil were reactive, jerks were normal, plantar flexor, CSF was done, 5 cells, all mononuclear. So what are the possibilities? Pre-BLL with CNS relapse, yes. Drug-induced meningeal inflammation because the child was on chemotherapy, also on antiepileptics. Meningoencephalitis is a possibility. Autoimmune encephalitis, yes, definitely. CNS vasculitis or brain abscess. These are the possibilities. So as we progressed, broad spectrum antibiotic, of course, was given, antiepileptics, seizure control with many antiepileptics, CSF analysis repeated, still no conclusion. MRI brain was done, and it showed features suggestive of abnormal signal intensities in thalamus, internal capsule, and other places, demyelinating lesions, and CSF PCR showed human herpes virus 7, which is a relatively uncommon even in immunocompromised patients. And there are a few reports I will show. Facial twitching persists, rapid shallow breathing. The child was kept in neuroprotection after 72 hours, had focal seizure, so antibiotics had to be upgraded. And MR spectroscopy was done. There were prominent lactate peak, reduced NAA, so this feature was consistent with encephalitis. And of course, to rule out the other autoimmune and others, serum MOG was negative, oligoclonal band was negative, but intermittent seizure persisting. So there are reports of human herpes virus 7 associated encephalitis. It was thought that human herpes virus events is relatively innocuous. But then again, there are reports, and this child had human herpes virus 7 encephalitis. Then we had avian influenza virus also, H9N2. A 4-year-old child, hyperactive airway disease history, presented with fever, distress, seizure, influenza B and adenovirus, both were positive, treated and recovered and readmitted after 7 days. And there were recurrence of distress. So this time, nasopharyngeal swab were sent for RT-PCR and it showed H9N2 influenza A. And then, of course, there were history of exposure to poultry at home. Now, this avian influenza A H9N2 was notified to WHO from India first in 2019, then again on 22nd May 2024. Of course, further sporadic human cases could occur, and this virus is one of the most prevalent avian influenza virus circulating in poultry in different regions. And again, by the human behavior, by the host, agent, and environment, by this interaction, this bird flu can manifest in human also. Another case, 45-day-old baby, cough and cold for 3 days, fever 1 day, breathing difficulty 12 hours, a very common feature. Tachypnea was there, unable to suck properly, saturation low, room air. There were crepitation, shifted to PICU, high frequency nasal cannula was put and oxygen was started through the nasal cannula, high frequency. WBC was 4,350, neutrophil 50, CRP 73. Others were normal. You see the chest X-ray. Gas showed acidosis. Meropenem and Vanco was started because it's a 1.5-month-old baby. Next 4 hours, repeated desaturation, persistent tachypnea, 1 episode of apnea, pressure control ventilation with FiO2 60. And bronchoalveolar lavage was sterile, no bacteria, but the biofire showed respiratory syncytial virus. There was no improvement in the next 72 hours. Persistent rogue-led fever. WBC was 5,000, CRP 52. So considering the clinical condition, ribavirin was started. After starting ribavirin, you can see the improvement in the X-ray. The child received ribavirin for 7 days, though meropenem was continued considering the critical condition of the child and the age, but could be extubated for 5 days, and then oxygen was delivered through nasal prong. So respiratory syncytial virus commonly presents as bronchiolitis, which is so common. We get it so frequently, but sometimes the respiratory syncytial virus infection may also be very severe. So that's why we have faced these outbreaks in many parts of the world. It peaks usually in monsoon to early winter, June to October, and there may be small peaks in December, January, February also. Though the seasonality from a geographic overview, if we see RSV, Indian studies, there are in North India, peaks in winter. In Eastern India, again, it's usually around monsoon like South India, and in Western India also highest during monsoon. And if you see this is from the ICMR, National AIDS Research Institute, Pune, and it shows that RSV remains a leading cause of respiratory infection across four regions of the country. You can see north, east, west, and south. The light blue is the RSV, and overall it was 29%. So it is common and sometimes it may be severe. But what we can look forward, some preventive strategies are in the horizon, like the nirsevimab, which can be given right after birth as a prophylaxis. It's just like a vaccine just before the RSV season or in the first year of life during the RSV season also. So it's an intramuscular injection, so it can help in preventing RSV infection and the complications. So I tried to present few of the viral infections that may present in various forms, and sometimes that may be very difficult to manage also and very difficult to detect. But luckily in our armamentarium we have the many tools to detect the viral infection, the PCR, the biofire, depending on the availability and proper indication, we may use judiciously to demystify the viral infection that we are encountering with such varied manifestation. Thank you so much.
Thank you, Jaideep, for this excellent presentation on different types of viruses attacking the respiratory system, the central nervous system, and in general, the discussion was mainly based on the cases, and that is what I liked most. So, some of our audience viewers, they have certain queries. So I just put them across to you, and one of them is, of course, about the respiratory viral infections, and one of the delegates wants to know as to what is the way to differentiate a viral respiratory infection from a bacterial infection, and whether there are any criteria which would enable us to differentiate, because many times it's a big challenge to differentiate viral from bacterial, particularly in the respiratory infections. And then many of our colleagues, they land up prescribing antibiotics. So when we are discussing rational use of antibiotics, it is necessary that we are sure that this is not bacterial, so that we can avoid antibiotics. So what are your views on this?
Yes, sir. Thank you. Now, number one, let us reiterate, yes, and any child with fever and respiratory distress below 5 years, as per WHO and national guidelines, they warrant antibiotics. A basic antibiotic like amoxicillin is adequate if the child can be managed in outpatient department. So a fever with tachypnea, antibiotic is justified. Now, because we have to think of bacteria mostly, but something may just make us conscious. Like a viral infection usually presents with a prodrome, like an upper respiratory cough and cold, running nose, more cough. So there one must think of viruses as the cause, because bacterial pneumonia usually do not present with a prodrome of upper respiratory infection. Usually, again, I must say. Then a a pneumonia, which is behaving unnaturally, as I was showing here, that yes, there was a lobar consolidation, but again, it was not responding to antibiotic, because any lobar pneumonia is supposed to respond to antibiotic if it's a common bacterial infection. So if we go beyond that, beyond bacteria, then we have to think viruses. Again, there are a lot of options as far as investigation is concerned. Now, how much to investigate? Now, that's again debatable, because investigations for viruses, if we take from the upper respiratory sample, it may be colonization only. Say metapneumovirus, the paramyxovirus, the rhinovirus, those are all commensals. So how much to take from the upper respiratory viral isolation is questionable. If the child is sick, then we can take. So we have the option of bronchoalveolar lavage and also mini BAL, as we may say. If the child is really critical, even the child is not responding to antibiotics, then we may go for a lower respiratory tract secretions for the viral PCR or biofire, depending on availability. But I must reiterate the clinical judgment, basic investigation. A bacterial pneumonia will definitely have high WBC count with neutrophilia and also high CRP. If it's not corroborating, then we may think of viral pneumonia. But because investigations are limited, it is costly. And even if we diagnose a viral pneumonia, hardly there are any treatment as such. That's why prevention for viral pneumonia is more important. Whatever and the vaccines can be given, hygiene can be maintained. That is very important. The prevention of indoor pollutants like smoke exposure, passive smoking, uh, chronic respiratory conditions that may also exacerbate the viral infections.
Thank you. Thank you very much for that elaborate answer. So it is not always necessary to send the nasopharyngeal swab for viral respiratory panel. However, what has happened is in the metro cities, just because these panels are available, there are some of our colleagues who immediately send the nasopharyngeal swab for this respiratory panel, and then it's unnecessary expenditure. Many of these viral infections, as you said, they are self-limiting. It's okay, like as you did it for this case of adenovirus, the child is, getting prolonged fever, presentation is like lobar pneumonia, but the child is not responding to the routine antibiotic therapy. Then it's a different story. But otherwise, I don't think we should resort to the costly respiratory panels if diagnosis is not a big problem. Now, one important problem which our clinicians in practice face is related to influenza. You mentioned about a case of avian influenza in your presentation, but the usual case of H1N1 or any influenza subtype virus, usually the child will present with fever, headache, myalgia, weakness, and many times as the child progresses in a case of influenza, we know that oseltamivir, one of the antiviral agents used for the treatment of influenza, is started, but many times it is started little late. What is your opinion about this particular antiviral agent, particularly when a pediatrician is confused about whether this is plain simple influenza or whether it is bacterial infection? And in case if one starts both the antiviral as well as antibiotic very much in the beginning, then that's also something which is not rational. So how you tackle this particular confusion when a child is appearing, rather confronting us with symptoms where differentiation is little difficult? So how would you approach such a child?
Thank you, sir. First, I would like to mention that till 5 years of age, I will recommend influenza vaccination because that's a very essential vaccine because that may cause a lot of issues. Secondly, yes, we have oseltamivir for influenza, but again, oseltamivir has to be started within 5 days. Within 5 days, we often fail to suspect influenza and fail to diagnose influenza. Now, there are double-edged sword. If it's beyond 5 days, there is no point in starting oseltamivir. We should not start. And oseltamivir should not be started empirically also in all upper respiratory infection. Now, if a child is having viral like illness and it's a mild manifestation, then we may just wait. There is no need to do a PCR or start oseltamivir. If a child is very sick in an ICU, not responding to antibiotics, the blood picture is not matching with a bacterial pneumonia, then probably we are justified in doing a viral PCR, that too from the lower respiratory I mean bronchoalveolar lavage or mini bile sample, and start oseltamivir. If it's negative, then we may stop oseltamivir. As an OPD patient, only if a child is having severe respiratory features which is not matching with a viral bacterial infection, then we may go for a viral PCR within 4 days. If it's positive, then we start oseltamivir. So my suggestion is that no empiric use of oseltamivir, then it will be another antibiotic or antiviral which will go to the drains. Number one. Number two, no hasty viral PCR or biofire, and hasty starting of oseltamivir also. This only if the child is sick and definitely is in a great distress, we are justified in starting oseltamivir. If negative, we stop it.
Okay, thank you for that. Jaideep, in one of your cases, you mentioned about dengue fever, and dengue is really something which creates lot many problems in our day-to-day practice, and there are quite a few confusions which we need to demystify. And one of them is related to this NS1 antigen, and in the rainy season or in the post-monsoon season also, many of our colleagues, as soon as the child comes on day one with fever, simply because there are plenty of cases of dengue in the community, they immediately send the sample for NS1, IgG, and IgM. So this particular serology of dengue fever, I think, needs to be demystified. So, can you, in brief, tell our listeners about the time when you can send the blood sample for serology in a child with dengue fever or a suspected case of dengue fever?
Yes. Now, NS1 is an antigen which becomes positive very early in the dengue, in 1 to 2 days. So during that particular season, when there are cases all around, we are justified in sending NS1 till day 4 of fever. Now, within day 4, there is no role of IgG and IgM because it takes time to rise. If it's beyond 5 days, there is no role of NS1. We have to do IgM and IgG. Only in the borderline phase, 4 to 5 days of fever, we are justified in doing NS1, IgG, IgM all. Because there may be some confusion, because NS1 will be decreasing, IgM will be rising. IgG doesn't rise in acute dengue, but it will reflect it whether it's a secondary dengue or a past infection. So NS1 early, IgM beyond 5 days. That's the dictum. But again, monitoring and repeating the PCV and platelet is the most important management for dengue.
Thank you for that answer. And maybe one of the last few questions, one of the listeners wants to know about fever and rash, which are very common manifestations of viral infections, particularly like measles or chickenpox and others. However, some illnesses which present with fever and rash, particularly rickettsial diseases, where treatment in the form of doxycycline is available. The listener wants to know as to whether it is possible to differentiate different kinds of rashes which accompany the fever, and what is the way to go forward in such cases.
Yeah, see, commonly what people confuse is the measles. But measles, characteristically, the fever comes down in day 4 or 5. After a very high fever, it suddenly comes down. Then the rashes appear, and the typical distribution of the rashes. So that's measles. And of course, so we have to be very careful about measles, and best is to prevent it. Number two, chicken pox is usually the typical pleomorphic rash, and the vesicles. And again, fortunately, the chicken pox incidence has come down due to various reasons. So these are all self-limiting, and there is no definite treatment. Yes, we are scared about scrub typhus because that's one of the condition which is treatable and very easily treatable with doxycycline. It works wonders, and doxycycline can be given at any age without much side effect. So scrub typhus infection, typically the children are having high fever, looks very sick, and the rash is maculopapular all over the body, and that sickness of the child will be disproportionate to a viral infection. So that will make us alert. And if we suspect scrub typhus clinically, we are justified in starting doxy empirically pending the scrub typhus IgM report. If it's negative, we can stop doxycycline also. But doxycycline should be started early if scrub typhus is suspected, because it's a quite severe infection and the children often go into various complications of scrub typhus. Other than that, yes, there are other rashes like mpox or Zika virus rashes, but those are very rare. And I must be very frank in confessing that I haven't seen any Zika or mpox. It's just a theoretical discussion that I just for completion of the newer viruses that I had. But all rashes are not due to measles. So even if the parents tell that the it's a measles, we must be very sure in excluding this one scrub typhus before we diagnose it as measles.
Uh, I fully agree with you. And there is a last question from one of the listeners, and that is about a mother having hepatitis B seropositivity in pregnancy, delivers a baby, and the government sectors, they usually continue to give hepatitis B vaccine at the time of birth. So, what should be the approach for a newborn born to a mother who is hepatitis B positive? So that's the last question. So maybe you can clear the confusion around this.
Hepatitis B vaccine has to be given, but a child born to hepatitis B positive mother must receive the hepatitis B immunoglobulin, and that should be preferably given within 12 hours. And it's an IM dose, so it can be given and it's easily available also. But hepatitis B vaccine should be continued as usual with one more dose at 1 year. If hepatitis B immunoglobulin is not available, then also the vaccine has to be continued. And if it is available within 7 days, then also hepatitis B immunoglobulin should be given.
Thank you very much. So we have almost all the different viral infections which are associated with some sort of confusion in the minds of our colleagues. As we are closing down, there is a last question which has come up, and one of the listeners wants to know about this hand, foot, mouth disease. So, will you just elaborate a few points about this disease so that we can just wind up the discussion after some time? Yeah.
Coxsackie virus infection, usually mild as an infection, but causes great distress to the child and their family, because the mouth is affected and the child absolutely refuses to take food and the whole family forces food. There is no treatment as such. It usually cures within 4 to 5 days. Only there is a slight risk of myocarditis by Coxsackie virus, that as a doctor and clinician we should be aware, but we should not scare the parents. We must call the child for follow up and examine the child properly. Otherwise, Coxsackie is a very mild disease.
Thank you, Jaideep. We have had a very, very elaborate discussion about various, viral infections in the pediatric age group. I am aware that it's very difficult to cover all the viral infections, but then I think Dr. Jaideep has covered almost all the systems, respiratory system, the CNS, and even hepatitis B, that is hepatology, and so on and so forth. And I am very much thankful to him for bringing out important points related to the confusing presentations of certain viruses. Particularly, he has elaborated with the help of the case in relation to the adenovirus, which presented like lobar pneumonia and finally it turned out to be adenoviral pneumonia. So, thank you, Jaideep, for this particular presentation, and I hand over the proceedings to Surekha Kare. Thank you.
Yeah. Thank you, sir. So, as we conclude today's Pediatrician Pathshala Scientific Convention Module 2 and Issue 5 on demystifying common viral infections, we want to extend our heartfelt thanks to our today's esteemed and honorable speaker, Dr. Jaideep Chaudhary, for his insightful topic coverage and covering all the different types of viral infections. It was an honor to have you on board, sir, and having you on Pediatrician Pathshala today. We thank you, our today's moderator and the scientific coordinator, originator of Pediatrician Pathshala, none other than Dr. Pramod Jog, for skillfully guiding, joyfully guiding the today's session, as always. A sincere thanks to Dr. Vanmati for starting the today's session. And lastly, sincere thanks to all the pediatricians who joined us today for your valuable presence and commitment to enhance pediatric care are truly appreciated. Thank you, everyone. Lastly, Doctor, you can generate the participation certificate signed by Dr. Jaideep Chaudhary and Dr. Pramod Jog on Pediatrician Pathshala platform with just one click away. And we look forward to see you in our upcoming sessions of Pediatrician Pathshala Module 2. We have 2 more sessions under Pediatrician Pathshala Module 2 for rational use of antibiotics in pediatric practice. With one more exciting topic, we'll see you in next month. So thank you so much once again. Have a great evening. Thank you, everyone.
Thank you. Thank you. Thank you.
Thank you.